So today we'll discuss about the drugs for schizophrenia. In short, we can tell these all under antipsychotic drugs and drugs for bipolar disorder. So in the previous class, already we have discussed about the antidepressant drug. Okay. So there are, just for recapitulation, there are different subtypes of the antidepressant drug. For example, we have read about the tricyclic antidepressant and its derivative tetracyclic antidepressant, then monoamine oxidase inhibitor, reversible monoamine inhibitor A selective, which is selective, also known as RIMA, moclobemide. Then we have discussed about the most important selective serotonin reuptake inhibitor SSRI, and then SNRI, serotonin and norepinephrine reuptake inhibitor, and different other atypical antidepressants. Similarly, we will discuss today about the antipsychotic drugs. So first, antipsychotic drugs are mainly needed in schizophrenia and different types of the diseases that are related to schizophrenia, like schizoaffective disorder, schizoid disorder. These are different spectrums of the schizophrenia disorders. So what happens in schizophrenia? There are different types of the positive and negative symptoms. So ultimately these symptoms all come due to the changes in the neurotransmission within the brain. So already you know something about the dopaminergic pathways from the physiology. There are 4 dopaminergic pathways that are involved in this schizophrenia pathogenesis and its management. For example, there are mesolimbic and mesocortical pathways. So mesolimbic, mesocortical, these two pathways, mesolimbic particularly is associated with the positive symptoms when there are dopamine excess, and mesocortical pathways is associated with negative symptoms when there is dopamine excess. So these are the pathways that the neurotransmitter is the dopamine. When there is excess of the dopamine, that will lead to positive or negative symptoms. So apart from this, there are nigrostriatal pathways, you know. When we are treating the disease of the schizophrenia, we are blocking this dopaminergic transmission. So ultimately, when there is reduced dopamine in this nigrostriatal pathway, that also leads to some adverse effect, and this comes due to the nigrostriatal pathway dopaminergic blockade. This is known as the extra pyramidal symptoms. Extra pyramidal symptoms. Okay, we will read about this. And another pathway is the Tuberoinfundibular pathway, that is also associated with dopamine. If there is dopamine excess, there will be prolactin, increase of the prolactin, that leads to different types of the endocrine problems, like there may be decreased libido, there may be some amenorrhea and galactorrhea, like this. So mesolimbic and mesocortical pathways, these are the dopaminergic pathways. When there is dopamine excess, there may be some schizophrenia like features. Apart from this, serotonin pathway is also involved. So the newer antipsychotic drugs are basically blocking both the dopamine as well as the serotonin pathways, and that ultimately leads to both management of the positive and negative symptoms. Apart from these two important dopamine and serotonin, glutamate, GABA, glycine, these are the different other neurotransmitters that are also involved in schizophrenia. There are also some physical changes in the brain if the schizophrenia is continuing for a long period of time. So let's just start about this. So this all comes under the psychosis. So psychosis is basically mental illness that is characterized by distorted or non-existent sense of reality. That is, the sense of reality is lost. Okay. So common psychotic disorders may be major depression or mania with psychotic features. There may be substance induced psychosis, dementia with psychotic features, delirium with psychotic features, brief psychotic disorder, delusional disorder, schizoaffective disorder. These are the different other schizophrenia like illness where these antipsychotic drugs are also useful. And lastly, the schizophrenia, which is the prototype, already we have discussed. So these antipsychotic drugs are used primarily for the treatment of the schizophrenia, and also already we have seen that is depression with psychotic features. That is, we are using antidepressant drug plus some antipsychotic drugs like this. So basically we have to continue the drug in most of the cases for a long period of time, perhaps the lifelong. They often decrease the intensity of the hallucination and delusions. These are the positive symptoms. and permit the person with schizophrenia to function in a supportive environment. So basically these are social affective disorder, and the different positive symptoms are treated when we are using different types of the common antipsychotics or typical antipsychotics. But it is often difficult to treat the negative symptoms of the schizophrenia. Negative symptoms means avolition, anhedonia. The patient will not do anything, or there may be unpleasant sensation. So these are the negative symptoms. This mainly happens due to the changes in the serotonergic neurotransmission. So the newer antipsychotic drugs or atypical antipsychotic drugs that basically block both the dopamine and serotonin pathways that are more beneficial in management of the negative symptoms of the schizophrenia as well as the positive symptoms of the schizophrenia. Okay. So schizophrenia is a type of chronic psychosis which is characterized by delusion, hallucinations often in the form of voices, like some third person is talking about him or her, and thinking or speech disturbance. All these are different types of the problems in various heterogeneous manner that may happen in the schizophrenia. The onset of illness often during late adolescence or early adulthood. Usually it starts with some acute episode and then it will continue as a chronic syndrome with some occasional flare up. It occurs in about 1% of the population as a chronic and disabling disorder. It has a strong genetic component. It has been seen that if there is some first degree relative with schizophrenia, there is approximately more chances of having schizophrenia than another person having second degree relative with some schizophrenia. And it has also been seen that if there is monozygotic twins, there is 50% chance that the other twin also have schizophrenia. In case of the dizygotic twins, it has been decreased to approximately 10 to 15%, like this. So these are the antipsychotic drugs. These are about the chemical groups, and these are the names of the antipsychotic drugs. So these, the starter ones, these are the comes under the typical antipsychotic drugs or first generation antipsychotic drugs. They mainly blocks the dopaminergic transmission with little effect on the serotonergic transmission. Example is the under the phenothiazines group, chlorpromazine. Chlorpromazine is the oldest antipsychotic drug. This was discovered in around 50s. Then comes the next ones like triflupromazine, thioridazine, trifluoperazine, flufenazine. Within the butyrophenons, there are haloperidol, trifluperidol, penfluridol. Within the thioxanthines, flupentixol. There are some other heterocyclic compounds like pimozite, loxapine, etc. So these are the typical or first generation antipsychotics. The most common is the chlorpromazine, commonly can be used. Thiorizazine is used, trifluperazine is used, haloperidol is very commonly used, flupentixol is used, pimozite, these are used. These are commonly used. And these atypical antipsychotic drugs are the second generation antipsychotic drugs. Example is the clozapine, which was the first one discovered and still used mainly in case of the resistant schizophrenia. Risperidone, Olanzapine, Quetiapine, aripiprazole, ziprasidone, amisulpride, zotapine. Okay. So the main difference between this first generation and the second generation is first generation mainly blocks the dopaminergic neurotransmission. The second generation blocks both the dopamine as well as the serotonergic neurotransmission. But the dopamine neurotransmission blockage is somewhat lower. Since the dopaminergic neurotransmission blockade is somewhat lower, so there is less effect on the nigrostriatal pathway. Since there is less effect on the nigrostriatal pathway, that's why the common adverse effects of the typical antipsychotics is the extra pyramidal syndromes that mainly happens due to the low dopamine in the nigrostriatal pathway. That will not happen in case of the atypical antipsychotics. But atypical antipsychotics or the newer antipsychotics are associated with different types of the metabolic problems. There may be onset of the obesity, there may be diabetes mellitus, hyperglycemia, dyslipidemia. These may all happen due to the atypical antipsychotics. And there is one typical adverse effect of the clozapine is the agranulocytosis. So the patient, if they are on clozapine, we have to monitor their complete blood count, that is the WBC count, regularly to see whether there is agranulocytosis is setting in or not. Okay. So divided into first and second generation, already we have discussed. First generation drugs usually may be low potency or high potency. So for this first generation and also for second generation drugs, for blockade of the positive symptoms of the schizophrenia, minimum 60% blockade of the dopaminergic receptors is needed. So if this dopaminergic blockade becomes more than 80%, there will be more extrapyramidal symptoms. So that's why this the older ones, they have approximately 70%, 80%, 90% blockade of the dopaminergic transmission. That's why there will be more extrapyramidal symptoms. But in case of the atypical or newer ones, the dopaminergic blockade is somewhat less. That's why, since they are not crossing the 80% blockade of the dopamine receptors, the extrapyramidal symptoms are less, but the positive symptoms are also managed. The dopamine overactivity hypothesis, already you have discussed. So there will be dopamine overactivity in the neurotransmission. That's why that leads to the development of the first therapeutic class of these antipsychotic drugs. These are the typical or first generation antipsychotic drugs. So these are also known as the neuroleptic. They act through the D2 receptor blockade but are associated with the extrapyramidal side effects. So this conventional, typical or traditional antipsychotics acts by competitive blockade of the dopamine D2 receptors. When they are blocking the dopamine D2 receptors, dopamine cannot act on the dopamine receptors, and dopaminergic neurotransmission will be diminished. Most likely they are associated with extrapyramidal symptoms. Time and again I am saying, particularly drugs that bind tightly to dopaminergic neuroreceptors. That is, if there is blockade of the dopamine receptors more than 80%, there will be more tightly binding, there will be more extrapyramidal symptoms. That will be very much problematic for the patients. Patients cannot continue. Second generation antipsychotics and newer ones are associated with higher risks of metabolic side effects. Already we have discussed, there may be some dysglycemia or hyperglycemia, dyslipidemia, obesity, weight gain, hypercholesterolemia, all this can happen. So they are basically blocking both the serotonin and dopamine as well as the other receptors also. They are also blocking glutamate receptors like this. So second generation antipsychotics or atypical antipsychotics, remember these are now the first line agent for the management of the schizophrenia. So if the schizophrenia is diagnosed, we are starting with the second generation or atypical antipsychotics. Okay. So they basically act both the dopamine as well as the serotonergic neurotransmission. So when we are starting with this antipsychotic drugs like that of the antidepressant drugs, usually some times is needed for its response. Approximately minimum 2 to 4 weeks is needed. So clozapine, which is an antipsychotic drugs, atypical antipsychotic drugs, has shown to be an effective antipsychotic drug with minimal risk of extrapyramidal symptoms. Extrapyramidal symptoms is minimum. All the atypical agents have minimal extrapyramidal symptoms, but maybe in some patients there may be some extrapyramidal symptoms may happen. Mainly this clozapine is used in refractory patients because of the serious adverse effect. The most serious adverse effect is the agranulocytosis, which happens due to the bone marrow suppression. Apart from this, there may be some seizures and cardiovascular side effects. So clozapine, within the atypical antipsychotic agents, clozapine is again an unique one that is usually reserved for last. Other antipsychotic agents like Olanzapine, Risperidone, etc. are first used, and if it is not controlled, the schizophrenia is not controlled, at the last clozapine is used. Mechanism of action, dopamine antagonism and serotonin receptor blocking activity, already we have discussed. So all of the first generation and most of the second generation antipsychotic drugs block D2 dopamine receptors in the brain and periphery. So dopaminergic receptor, yes, sir. Dopaminergic receptor blockade. So serotonin receptor blocking activity. So they are basically blocking the inhibition of the serotonin receptor, mainly the 5-HT2A receptor. So within the dopamine, the main blockade is the D2 receptor. Within the serotonin, the main blockade is the 5-HT2A receptor. Okay. So apart from this, other serotonergic and dopamine blocking also happens to some extent. So for example, you can see clozapine has high affinity for D1, D4, 5-HT2, muscarinic and alpha adrenergic blockers. That is, different other receptors may be blocked by this. Risperidone, for example, also blocks the 5-HT2A receptors like this. So this is the mechanism of action already we have discussed. That is, this is the dopamine. Dopamine, there is dopamine, more dopamine is present here. We are blocking the dopamine receptor. So there will be less dopamine action and there will be decreased intracellular response. Risperidone already discussed, that also blocks the 5-HT2A receptor. Aripiprazole is basically a partial agonist at D2 and 5-HT1A receptor as well as an antagonist of the 5-HT2A receptor. So like that of the antidepressant drug, different drugs have different agonistic and antagonistic action in different receptors, and accordingly their effectivity, potency as well as the side effect profile varies from one agent to another agent. So ultimately all acts on these dopamine or serotonergic receptors, but some are partial agonists, some are antagonists, some are less potency, some acts on some other receptors like this. Quetiapine, that blocks D2 receptors more potently than the 5-HT2A receptors, but is relatively weak at blocking either receptor. So its low risk for extrapyramidal symptom may also be related to the relatively short period of time it binds to the D2 receptor like this. These are examples about the differentiation. So you can see this is the relative affinities of the D2 receptor. Clozapine, the relative affinity to the D2 receptor is less for clozapine. Chlorpromazine is a typical antipsychotic drug whose D2 receptor affinity is more. Haloperidol is more since it is of high affinity. Haloperidol is of typical antipsychotic which is a very high affinity for the D2 receptor blockade, more than that of the this chlorpromazine. Chlorpromazine is the prototype drug that was first discovered. So most antipsychotic drugs have affinities at D2 dopaminergic receptors that parallel clinical potency. And clozapine differs from the typical antipsychotic drugs in having a similar affinity for both D1 and D2 receptors also. So this is the relative affinities at D1 receptor. Very less agents act on the D1 receptors, one of which is the clozapine. They have action on the D1 receptors also, unlike that of the other agents. So this is just differentiation between the different agents. So the actions of the antipsychotics, the clinical effects of the antipsychotic drugs appear to reflect a blockade at dopamine and the serotonin receptors. Already you have seen. Many of these agents also block the cholinergic, adrenergic and histaminergic receptors. That also leads to adverse effect as well as some effectivity also. However, the undesirable side effects of the antipsychotic drugs often result from pharmacological actions at these other receptors. So you can see these are the antipsychotic drugs that act on different other receptors. Like this thyroidazine, chlorpromazine, they also act on the cholinergic or muscarinic receptors. So there may be some anticholinergic side effects. Chlorpromazine also acts on alpha adrenergic receptors. All but particularly haloperidol, fluphenazine, thiazanthine that acts on other dopamine receptors also. Risperidone, clozapine acts on different other serotonin receptors. Chlorpromazine, clozapine also acts on the histaminergic receptors, H1 receptors. That is, different receptors can be affected by these antipsychotic drugs. So antipsychotic effects, positive symptoms and negative symptoms. Positive symptoms, all antipsychotic drugs basically block the positive symptoms. Mostly the typical antipsychotic drugs block only the positive symptoms. Atypical ones block both positive as well as the negative symptoms. Positive symptoms, most common is the hallucination and delusion. Negative symptoms are the blunted affect, apathy, impaired attention, anhedonia, cognitive impairment, etc. that are mainly affected by the second generation or atypical antipsychotic, not the first generation antipsychotic agents. Many second generation agents such as clozapine can ameliorate the negative symptoms to some extent. So negative symptoms treatment is more difficult than the positive symptoms treatment. Now coming to the extra pyramidal effects, what we are talking. So extra pyramidal side effects are the most common adverse drug reaction of the typical or first generation antipsychotic agents due to their blockade of the dopamine receptors, mainly in the nigrostriatal pathway. Okay. So there may be dystonia. Dystonia means there is sustained contraction of muscles leading to the twisting and distorted posture. Sustained contraction happens here. There may be some Parkinsonism-like syndromes. There may be some Parkinsonian syndromes. There may be some akathisia. Akathisia means motor restlessness. Tardive dyskinesia. Tardive dyskinesia is involuntary movements, usually of the tongue, lips, neck, trunk and limbs. Continuous movement, like ball rolling movement. The patient will continue doing like this, like something, like some involuntary movements of the lips or teeth. So these are the tardive dyskinesia that can occur with both acute and chronic treatment, mostly with the first generation antipsychotic agents. So already I have discussed blockade of the dopamine receptors in the nigrostriatal pathway is mainly associated with this. The second generation antipsychotics have lesser or fewer extrapyramidal adverse effects. Antiemetic effects may happen with some agents. Most of the antipsychotic drugs have antiemetic effects except the aripiprazole. This happens due to the blockade of the D2 receptors of the chemoreceptor trigger zone of the medulla. Anticholinergic effects are particularly thyroidazine, chlorpromazine, clozapine, olanzapine. That is both the typical as well as atypical agents. Some agents can produce anticholinergic side effects due to the blockade of the muscarinic cholinergic receptors. So there may be some blood vision, dry mouth, confusion, inhibition of the gastrointestinal and urinary tract smooth muscle. That is, there may be some urinary retention, constipation. All this can happen. Again, in case of the clozapine, usually that increases the salivation. So there will be hypersalivation with the clozapine. So clozapine is an exception to this. The anticholinergic effects may actually assist in reducing the risk of extrapyramidal symptoms with this agent. So this is just opposite. So those agents which have more anticholinergic side effects, they have very less extrapyramidal side effects. There may be blockade of the alpha adrenergic receptors that may lead to orthostatic hypotension and lightheadedness. There may be some temperature regulating center alterness. So body temperature may varies with the environment, that may happen. In pituitary, that may block the D2 receptors, increase in prolactin release. Already I have discussed that there is another pathway, Tuberoinfundibular pathway, where the dopamine receptor blockade leads to increase of the prolactin. That may lead to this type of different types of the hyperprolactinemia like syndromes. Sedation occurs with those drugs that are potent antagonists at the histaminergic receptors like chlorpromazine, olanzapine, quetiapine, clozapine. Sexual dysfunction may also occur with the antipsychotics due to various receptor binding characteristics, very common. Triflupromazine is more potent than the chlorpromazine, used mainly as antiemetic, mainly in case of the psychosis patients. Thyroidazine is a low potency phenothiazine. They have marked central anticholinergic action. Trifluporazine and fluphenazine, they are high potency piperazine side chain phenothiazines with minimum autonomic actions. Haloperidol, very commonly used mainly in case of the acute cases. This is a potent antipsychotic, preferred drug for acute schizophrenia, Huntington's disease, Gilles-Diller Tourette syndrome. These are different types of other psychotic syndromes, Tourette syndrome or Huntington's chorea, schizophrenia, or the patient is in severe psychosis where we have to give the haloperidol immediately. Penfuridol is an exceptionally long-acting neuroleptic recommended for chronic schizophrenia, affective withdrawal and social maladjustment. So these are the different areas where we can use this type of the typical antipsychotic agents. So typical or conventional antipsychotic agents are also used in these scenarios. Atypical or second generation, these are now the first line agents for the management of the chronic schizophrenia. Extrapyramidal side effects are minimal. They tend to improve the impaired cognitive function. They tend to improve the negative symptoms as well as the positive symptoms of the schizophrenia. Clozapine, which is the first atypical antipsychotic agent, they have D2 receptor blocking action, but this action is weak. They have some D1 receptor blocking action also. They are also additional blockade of the 5-HT2 alpha adrenergic as well as the some relative selectivity to D4 receptors also. So different other receptors can be blocked. They produces few or no extrapyramidal symptoms. Tardive dyskinesia is rare and prolactin level also does not rise. So there will be no hyperprolactinemia. Both positive and negative symptoms of the schizophrenia are relieved. Clozapine is the most effective drug for refractory schizophrenia. That is, we are using different drugs, but the schizophrenia is not responded. Then we have to use the clozapine as a last line agent. The differing pharmacological profile is basically leads to their action in case of the refractory cases. They are quite sedating also, because already we have seen they are blocking the histaminergic receptors. They are moderately potent anticholinergic, but paradoxically they induces hypersalivation. So there will be hypersalivation in clozapine, but in all other antipsychotic drugs there will be less salivation. So clozapine is metabolized by different cytochrome P450 enzymes. So an average TRP is approximately 12 hours. So major limitation or major adverse effect of the clozapine, remember, is the agranulocytosis, which mainly happens in approximately 0.8% of the patients, and also different other blood dyscasias that are quite disabling, and we have to stop the clozapine in some of the patients. So weekly monitoring of the leukocyte count is required. So we have to count the leukocytes every weeks, and then it will be increased to every 2 weeks to see whether there is agranulocytosis or not. Metabolic complications like weight gain, hyperlipidemia, precipitation of diabetes is also happen. This is the common adverse reaction of different other atypical antipsychotic agents. High dose can induce seizures even in neuroleptics also. Other side effects of sedation, already we have seen, unstable blood pressure, tachycardia, urinary incontinence may happen. Few cases of the myocarditis have been reported. They may progress to death also. Clozapine is used mainly as a reserve drug in refractory schizophrenia, particularly due to these adverse reactions, particularly the agranulocytosis. So remember always, clozapine is associated with agranulocytosis. That's why weekly monitoring of the WBC count is necessary for management of the schizophrenia when we are using clozapine. Next, coming to the risperidone, very commonly used drug nowadays, which causes both the dopamine as well as the 5-HT2 receptor blockade. In addition, it has high affinity for alpha 1, alpha 2 and H1 receptors. These may contribute to some efficacy also. So when we are blocking some alpha receptors, it has been seen there is some more efficacious, as well as some adverse effect like postural hypotension when we are blocking the alpha receptors. Blood pressure can rise if it is used with the SSRI. So when we are using both SSRI and risperidone, very commonly used, we have to monitor the blood pressure also. Risperidone is more potent D2 blocker than the clozapine. Okay, this is a more potent. Extra pyramidal side effects are less only at low doses. Prolactin levels rise disproportionately during therapy. So usually hyperprolactinemia is very common with treatment of the risperidone. It is less epileptogenic than clozapine, though it frequently causes agitation. Weight gain, incidence of the new onset diabetes is very common. Caution should be increased risk of the stroke in the elderly can also happen. So these are the different types of the metabolic problems that may happen with the continuous usage of the risperidone. Olanzapine, another drug that is very commonly used for the management. Olanzapine, remember, is most commonly associated with obesity. If the patient is continue taking the olanzapine, there will be severe weight gain, usually happens. They block the D2, 5-HT2, alpha 1, alpha 2 as well as some muscarinic and H1 receptors. Both positive and negative symptoms of the schizophrenia as well as some schizoaffective disorders are also benefited, and it is also used for the management of the mania. Potent anti-muscarinic, that's why it may cause dry mouth and constipation. They have weak D2 blockade, that's why the extra pyramidal symptoms are quite less. Little rise in prolactin level, but is more epileptogenic than high potency phenothiazines. They can cause weight gain and higher risks of impairing glucose tolerance or worsening diabetes. So again, the metabolic problems, the weight gain is very commonly associated with olanzapine, and incidence of the stroke is increased in risperidone as well as the olanzapine when we are continuing using. Quetiapine, another commonly used agent. They are short acting agent. T-half is 6 hours, usually twice daily dosing is needed. They blocks this 5-HT1A, 5-HT2, D2, alpha 1, alpha 2, H1 receptors blockade. Again, the D2 blocking activity is very low, that's why extrapyramidal symptoms are very low. Hyperprolactinemia side effects are also very low, it is minimal. So there may be some sedation, postural hypotension, urinary retention or incontinence, both can happen. Moderate weight gain, rise in blood sugar, different metabolic problems as well as anticholinergic side effects may happen. Another typical adverse effect of the quetiapine is the QTC prolongation. So within the ECG there are QTC, the interval is there, that will be prolonged in quetiapine. So when we are starting using this quetiapine, usually ECG is done for the patients. If the QTC is already prolonged somewhat, we should not use quetiapine, because prolonged QTC usually leads to arrhythmia, and that arrhythmia also may lead to death also. Okay. So usually the negative symptoms benefit is minimal in case of the quetiapine. It is efficacious in acute mania and bipolar depression also, because of which it is frequently selected for maintenance therapy. So usually those patients which have some bipolar disorder with psychotic features, we are using some other agents, and then the patient is on the remission. So for the maintenance therapy, usually the quetiapine is continued for the long period of time, because the metabolic side effects are less with quetiapine, because there will be very less weight gain, very less hyperprolactinemia, very less hyperglycemia or type 2 diabetes mellitus onset. That's why we can continue this for a long period of time. But for the starter, we have to do the ECG to see whether the QTC is prolonged or not. Again, it was metabolized by the cytochrome enzyme. So drug-drug interactions may be there with all the antipsychotic drugs that are mainly metabolized by the cytochrome enzymes. Aripiprazole, another drug that is commonly used. This is a unique because it is a partial agonist at the D2 and 5-HT1A receptor. Mainly the other agents are mainly the antagonists, but these are the partial agonists. So when the dopamine comes, they compete, and partially agonist, it causes the partial agonism of the D2 and 5-HT1A receptor. But it is antagonist at the 5-HT2 receptor. That's why the side effect profile is somewhat different. So high affinity but low intrinsic activity for the D2 receptor ultimately impedes the dopaminergic transmission by occupying a large fraction of the D2 receptor but activating them minimally. So they are blocking the D2 receptor largely, but their activity is minimal. So it is not sedating, may even cause the insomnia. They are not blocking the H1 receptors. Extrapyramidal side effects are not significant, as well as the different metabolic side effects are also not significant. That is the weight gain, hyperglycemia, dyslipidemia also very less. Again, here also some moderate prolongation of the QTC interval happens. That's why ECG is also necessary for this. Some nausea, dyspepsia, constipation, lightheadedness may happen. It is a long acting, half-life is very large, 3 days. Dose adjustment needs to be done after 2 weeks treatment. And it is indicated in schizophrenia, mania and bipolar illness. So you can see many of these antipsychotic agents are also used for the management, particularly for the long-term management of the bipolar disorder. Risperidone is a newer one. This is a combined D2, 5-HT2A2C, H1 and alpha-1 blocking activity. Antagonistic action at the 5-HT1D and agonistic action at the 5-HT1A receptor, and they are also moderately potent inhibitor of the 5-hydroxytryptamine and noradrenaline reuptake. So some anxiolytic and antidepressant property are present. So already we have seen that is the noradrenaline as well as serotonin reuptake inhibitors are the main way by which the antidepressant drugs act. So here they have some antidepressant actions also. So those patients who have both the depression as well as some schizophrenia like features, we can use the Risperidone. Low propensity to cause extrapyramidal side effects. This is mildly sedating, modest hypertension, nausea, vomiting may happen. Dose related prolongation of the QT interval may happen to some extent. Some antimuscarinic effects are very less, and it is also indicated in case of the mania. So Risperidone. Amisulpiride. Amisulpiride is a congener of the sulpiride which have a very high affinity for the D2 and D3 receptors and low affinity for the 5-HT2 receptors. So amisulpiride is basically comes under the typical or conventional antipsychotic, but these are the newer ones, some different actions, produces few extrapyramidal side effects, and they have also shown to improve the negative symptoms of the schizophrenia. Hyperprolactinemia may happen. Antidepressant property is also there with this amisulpiride. It is not sedative, rather insomnia, anxiety, agitation may happen. Again, QT prolongation may happen. Here is also, it is absorbed orally, half-life is approximately 12 hours. So amisulpiride, Risperidone, these are mainly have some antidepressant effect with some antipsychotic effects also. Zotapine is a dopamine D2, D1, 5-HT2, alpha-adrenergic and histamine releasing blockade action. They benefit both the positive and negative symptoms. Extrapyramidal side effects are very less. Lower seizure threshold, so incidence of the seizures may be there. Adverse drug reactions are mainly metabolic, so there may be some weight gain, hyperglycemia, etc. So more or less these are similar to all features according to the atypical antipsychotic agents. So the adverse drug reactions of all these agents already we have discussed. In the CNS, there may be some drowsiness, lethargy, mental confusion, etc. may happen. Tolerance to sedative effect may develop. Other side effects are increased appetite and weight gain. Usually this will not happen with the haloperidol. Aggravation of the seizures in epileptics. Different antidepressant drugs also we have seen that if the patient have some epilepsy like features, so the epileptic threshold will be decreased and the patient may land up to epilepsy also if there is somewhat overdose of this antipsychotic or antidepressant drugs. In the cardiovascular system, there may be postural hypotension, already I have seen, because most of these are blocking the alpha receptors. There may be some palpitation, inhibition of the ejaculation, especially with thyroidazine happens. Again, this happens due to the alpha adrenergic blockade. More common with low potency phenothiazines. QT prolongation and cardiac arrhythmias are a risk of overdose with thyroidazine, pimozide and ziprasidone. Excess cardiovascular mortality has been attributed to antipsychotic drug therapy. So already you have seen in case of the elderly persons, when we are using the antipsychotic drugs, particularly the atypical ones, there may be more chances of the stroke. So there may be more chances of the mortality is there. Anticholinergic side effects already discussed. Different anticholinergic side effects like dry mouth, blurring of vision, constipation, urinary retention may happen due to the blockade of the cholinergic receptors. Endocrine hyperprolactinemia, already we have been seen that it is very common. Amenorrhea, infertility, galactorrhea, gynecomastia may happen due to the increased level of the prolactin. Atypical antipsychotics except risperidone do not applicably raise the prolactin levels usually. Metabolic effects, so there may be elevation of the blood sugar, triglyceride level. Atypical antipsychotics mainly and some typical also like some thyroidazine, chlorpromazine, they causes high risk of precipitating diabetes mellitus. So this is so you can say that these drugs are mainly an example of drug induced diabetes mellitus. So diabetes mellitus, type 2 diabetes mellitus may happen due to some drugs. The most common example is some different types of the atypical antipsychotic agents. Trifluporazine, frephenazine, haloperidol, atypical antipsychotics, they have low or very low risks of these metabolic side effects. Okay. Extra pyramidal disturbances, already we have discussed again more with the typical antipsychotic agents. There may be already discussed like Parkinsonism like features. Another feature is the rabbit syndrome. Rabbit syndrome is the persistent perioral tremors, that is in the lips or the around the oral there will be tremor, continuous tremor. This is known as the rabbit syndrome. Acute muscular dystonia, like there may be some bizarre muscle spasm, mostly involve the linguofacial muscles. Akathisia means restlessness, feeling of discomfort, apparent agitation manifested as a compelling desire to move about but without anxiety. So there will be no anxiety, but the patient will continue moving about. The patient cannot sit still for even for 1 minute. So this is akathisia, restlessness. Malignant neuroleptic syndrome is very dangerous adverse effect of the antipsychotic agents. So there will be severe increase of the temperature that may happen associated with marked rigidity, immobility, tremor, hyperthermia, semi-consciousness, fluctuating blood pressure, heart rate. There will be myoglobin in the blood and myoglobin in the urine also. The patient may go to the coma and death also can happen. So malignant neuroleptic syndrome. The main treatment of the malignant neuroleptic syndrome is the dantrolene. So dantrolene we have read in the muscle relaxant chapter. In the skeletal muscle relaxant, one skeletal muscle relaxant, centrally acting skeletal muscle relaxant is the dantrolene sodium. Dantrolene sodium is mainly used for the management of the neuroleptic malignant syndrome. Okay. Tardive dyskinesia, it occurs late in the therapy, that is for years after therapy with the antipsychotic agents. This is the purposeless involuntary facial and lip movements like constant chewing or constant pouting, puffing of the cheeks, constant lip licking, some chorioattitoid movements. There are some rigid movements that may happen continuously. This is known as the tardive dyskinesia. There may be some hypersensitivity reaction also if the patient is allergic to some antipsychotic agents. So remember, these are the different extrapyramidal disturbances. Again, the extrapyramidal disturbances are more with the typical or first generation antipsychotic agents are very less or minimal with the atypical and second generation antipsychotic agents. So mainly it is used in the management of the schizophrenia, already we have discussed how it is used. Apart from this, it is also used for the management of the mania. The dose has to be individualized. It is usually started with the minimum and gradually the doses are building up. In chronic schizophrenia, the maximal therapeutic effect is after the 2 to 4 months of the therapy. Injectable neuroleptics like haloperidol injectable usually given when there is acute schizophrenia, acute depressed psychotic, we have to use the combination of the drug. For example, combination of some selective serotonin reuptake inhibitor or tricyclic inhibitor plus some atypical antipsychotic agents. This combination, fixed dose drug combination is also available. So we should use with depression with psychotic features. Anxiety, they have some anxiolytic effects. In some of the cases, again anxiety with psychotic features, we can use antiemetic, mainly in psychotic and MSEs, we can use is as antiemetic agent. Apart from this, in some intractable hiccup, a continuous spasm of the skeletal muscle, alcoholic hallucinosis, Huntington's disease, which is a genetic disease, Tourette syndrome, also known as the Gilles-Dilla Tourette syndrome, another genetic disease, where these are the indications where we have also have to use the antipsychotic agent. These are about the antipsychotic agents. Lastly, we'll discuss about the drugs that will be used for the treatment of the bipolar disorder. These are also known as the mood stabilizer or anti-manic agents. Many of these agents also come from the antidepressant and as are the antipsychotic agents. Only one that is mainly used as a only mood stabilizer or in bipolar disorder is the lithium. Lithium is only drug that is used only in case of the bipolar disorder or in mood disorder. Apart from this, the other drugs mainly that are also used as a first line agents are mainly antipsychotic or antidepressant drugs. So these anti-manic drugs or mood stabilizer are used in the treatment of mania, both to control the acute effects, acute mania. So mania is just on the opposite spectrum of the depression. So in the one spectrum, if there is severe depression, in the another spectrum there will be severe mania, acute mania, and to prevent their recurrence. And for bipolar disorder, bipolar means there is cycling of the depression and mania. Usually depression remains for months and then again mania remains for months. So this is known as the bipolar disorder. So in mood cycling, but are not effective in treating in depression. But so only in case of the depression, only those patients who have depression, these mood stabilizing agent or these drugs will not be beneficial. For only major depressive disorder or depression, we have to use the antidepressant drug. But in case of the bipolar disorder or bipolar disorder with depression, bipolar depression, we can use this drug. So these are also used treatment of the some cases of the schizophrenia. So you can see this is the severe mania in one spectrum, severe depression in the another spectrum, and within this spectrum there are different permutations and combinations where we have to use these different drugs accordingly. Like there may be some hypomania, there may be some mild to moderate depression also. Okay. So basically these are up and down. So bipolar depression. So antimanic drugs, lithium salts or lithium carbonate, which is main drug that is used for the management of the mania as well as the bipolar disorder. Apart from these, different anti-convulsion drugs like carbamazepine, valproic acid, lamotrigine. So these are the anti-epileptic drugs you have read. These are also used for the management of the bipolar disorder and mania. Different atypical antipsychotics just we have read like Olanzapine, Risperidone, Clozapine. These are also used for the management. Different benzodiazepines like also already we have seen the different benzodiazepines like diazepam like compounds that are also used for the management of these agents. Now first coming to the lithium. So lithium salt is the oldest and best known mood stabilizing agent. This lithium basically behaves like that of the sodium ion. So lithium salt, usually the lithium carbonate or lithium citrate are used, most commonly prescribed. 60 to 80% success in reducing the acute manic as well as the hypomanic state, and it reduces the risk of suicide related to the bipolar disorder. Bipolar disorder is very commonly associated with more risk of the suicide more than that of the only depression. So in those cases, if we are using this, the risk of the suicide will be decreased. So mainly it is used in the prophylaxis and treatment of the mania, prophylaxis and the maintenance treatment of the bipolar disorder, and also we have to build up. This is known as the lithium augmentation. where we are using some other agents for the treatment of the depression or psychosis with some bipolar disorder, we have to add the lithium for augmenting its action. So how it acts? Basically, they acts at the neurotransmitter level at the inositol pathway. So when we are using this lithium carbonate, the neurotransmitters which acts on the receptor and leads to different second messenger system, most commonly the inositol pathways, that will be blocked. So usually the inositol pathway IP3 and CAMP production will be hampered. So the signaling events revolving other receptors will be less when we are using lithium carbonate. So basically they act in the second messenger system. So you can see, so this when we are using the lithium, this inositol phosphate IP2 cannot be converted to the IP1, etc., etc. That ultimately leads to second messenger system by which the neurotransmitter goes. So there will be more neurotransmitter, more second messenger system in the case of the mania and bipolar disorder. So we are blocking this. So there will be less inositol, there will be less CAMP, there will be less DAG, diacyl glycerol. All this translates to the control of the bipolar disorder as well as the mania. So you can see lithium by inhibiting the recycling of the inositol substance. So you can see this is the recycling. This is basically a cycle. So when it comes outside, there will be neurotransmission. Again, it comes inside for the continuation of the cycle. So this recycling of the inositol synthesis is basically blocked by lithium. That causes depletion of the second messenger source PIP2. That is the we can see PIP2 is the phosphatidyl inositol 4,5 bisphosphate, which is a part of this inositol pathway, and therefore reduce the release of the further IP3 as well as the diacyl glycerol, inositol phosphate and diacyl glycerol. So how lithium acts? Lithium mainly acts in the second messenger system of the inositol pathway. So the second messenger system is basically needed when a neurotransmitter acts on the receptor. The second messenger system will be activated, so there will be some cellular changes and ultimately the effect will be seen. When this second messenger system that involves the inositol pathway, the recycling of the inositol pathway is blocked, there will be less IP3, DAG and phosphatidyl inositol. All these are the second messenger system, so there will be less neurotransmission. So this is completely absorbed from the gastrointestinal tract. They have long plasma half-life, approximately 20 hours. This is not bound to plasma proteins, not metabolized in the body. It is distributed in all body fluids, slow entry into the intercellular component, and its concentration can be detected in plasma, saliva and urine. So what happens? This lithium is a very narrow therapeutic index. That is, if we are increasing the lithium to very low amount, that will lead to severe toxicity, and if it is somewhat decreased, there will be no effect at all. So ultimately the patient can land up to suicide also. That's why we have to do the therapeutic drug monitoring by HPLC to see what is the plasma concentration of the lithium. This can be done from the plasma or from the saliva or from the urine. Usually this test is done, we are using the lithium salt, and minimum 5 to 6 hours we have to take the plasma, we have to analyze this in the HPLC to see what is the plasma concentration, and accordingly we have to increase the dose of the lithium or decrease the dose of the lithium. So remember, lithium is a classic example of the narrow therapeutic index drug, and that needs the therapeutic drug monitoring. So it has usually no effect in normal person. It stabilizes mood in affective disorder, very low therapeutic index, toxicity is correlated with plasma concentration. The toxicity is manifested by fine tremors, there may be some ataxia, there may be confusion, there may be delirium, convulsion, cardiac arrhythmia, all this happens. So how we can pick up that the patient may have some toxicity with lithium? So the patient will complain of fine tremors in the hands most commonly. So here we have to decrease the dose of the lithium and we have to check the plasma concentration. Treatment should be under normal sodium intake also, because the sodium and lithium are more or less similar. They are distributed more or less in the similar pattern. So that's why we have to check whether the patient is using some diuretic or not, if there is some dehydration or not. This ultimately, if there is some diuretic use or dehydration, that may land up to more concentration of the lithium in the blood. So that may be some toxicity. Okay. So lithium is clinically effective at plasma concentration of on an average 0.5 to 1 micromole. So 0.5 to 1, these are the plasma concentrations should be there. For this we have to check, this is the HPLC machine. So therapeutic drug monitoring by HPLC machine is needed. So above 1 millimeter, it produces a variety of the toxic effects, therefore monitoring of the plasma concentration is very essential. After the drug is started, 7 to 10 days must be elapsed before the antimanic effect is reached. Usually 7 to 10 days is needed. Lithium causes depletion of the membrane phosphatidyl inositol, already we have seen, and accumulation of the intracellular inositol phosphate. Hormone mediated CMP production is also decreased. So CMP production, which is another second messenger, is also decreased. So the adverse effect, there may be some anorexia, there may be diarrhea, there may be some action on the thyroid also, there may be some hypothyroidism. Seizures, again there will be decrease of the epileptic potential, there may be convulsion and death if plasma concentration reaches 3 to 5 micromole. So just you can see very low, 0.5 to 1 the lithium concentration should be there. If it will be increased, subsequently there will be increase of the different toxic effects. There may be some leukocytosis, nephrotic syndrome, polyuria, impotency, all can happen. This is a very toxic drug, adverse reactions and dose and concentration dependent. That's why dose and concentration monitoring is very important. Polydipsia and polyuria may also happen with the lithium treatment. The principal physiological lesion involved is the loss of ability of the collecting tubules to conserve water. So water will not be conserved under the influence of the antidiuretic hormone, resulting in excessive free water clearance. So there will be always chances of the dehydration. That's why the patient have to be hydrated well when we are using the lithium. Edema is a frequent adverse effect of the lithium treatment. It may be related to some effects of the lithium on sodium retention. So when we are using the lithium, there may be some sodium retention, there may be some edema also. Patients receiving lithium should avoid dehydration, already have discussed, and the associated increased concentration of the lithium in urine. Periodic test of the renal concentrating abilities should be performed to detect changes. That is, we have to check the kidney function also. What is the urea, what is the creatinine, what is the glomerular filtration rate of the kidney, that is to be periodically checked when we are using the lithium. There may be some cardiac adverse effect. The most common is the sick sinus syndrome. Sick sinus syndrome is also known as the bradycardia tachycardia syndrome, which is a definite contraindication to the use of the lithium. So if the patient already have this type of syndrome, we should not use the lithium, because ultimately it depresses the sinus node. Lithium depresses sinus node. The sinus node, which is the pacemaker of the heart, will be depressed. So there may be some sick sinus syndrome. There may be some TOF flattening may happen. Okay. So enlargement of the thyroid gland also may happen, that leads to hypothyroidism. So these are the different adverse effects. Again, lithium is transferred to nursing infants through breast milk, in which it has a concentration about 1/3 to 1/2 that of the serum. That's why lithium toxicity may happen in the nursing infants also. So newborns, that is marked by the lethargy, cyanosis, poor suckling, perhaps hepatomegaly. So this may happen, that is the problem. The issue of the dysmorphogenesis is not settled, but the most recent data suggests that lithium carries a relatively low risk of teratogenic effects. What does it mean? It means that because this lithium is mainly used in those patients who have bipolar disorder, and when the patient is become pregnant, there may be some pregnancy associated psychotic problems or pregnancy associated depression is also there. So if we are just stop the lithium or other antimanic drugs, that the patient may land up to suicide also. So we cannot immediately stop the lithium. So different research have been done. It has been seen that lithium is very less teratogenic. That's why, so if we can continue the lithium for a long period of time throughout the pregnancy period, if it needs to be continued. Otherwise we should stop because it is toxic. But in case of the nursing mother, that is the baby is delivered, then the baby is taking the breast milk, there will be coming of the lithium into the breast milk, that leads to different types of the adverse effect. So here we should decrease the dose of the lithium, or we can change to some other antimanic drugs. So drug interaction is there, renal clearance is reduced, about 25% by different types of the diuretics like thiazide diuretic. So diuretics should not be given when the patient is taking some lithium. Similar reduction in lithium clearance has been noted with several of the non-steroidal anti-inflammatory drug NSAIDs. Again, we have to judiciously use the different NSAIDs like ibuprofen, indomethacin. This interaction has not been reported for either aspirin or acetaminophen. Acetaminophen means paracetamol like agent. So we can use the aspirin or paracetamol, they are usually not problem, but we should not use ibuprofen or indomethacin like NSAIDs. All neuroleptics tested to date with the possible exception of the clozapine and some newer antipsychotics may produce more severe extrapyramidal symptoms when combined with lithium. So when we are combining lithium with some antipsychotic agents, there may be more chances of the different extrapyramidal side effects. Already we have discussed different extrapyramidal side effects like tardive dyskinesia, akathisia, rabbit syndrome, etc., etc. Apart from lithium, lithium is only used in these areas. Different other agents like anticonvulsants, carbamazepine, valproic acid, lamotrigine are used. Carbamazepine is superior to lithium for the rapid cycling bipolar disorder. It is a second line treatment for mania, drug of choice in partial seizure and tonic-clonic seizure, already we know. Mechanism of action, basically they are blocking the sodium channels, voltage dependent sodium channels, and also decrease the glutamate, which is an excitatory neurotransmitter. The side effects, GI upset, sedation, ataxia, some warfarin, since they are metabolized by the hepatic P450 system, there may be some drug-drug interactions. Severe bone marrow depression may occur. So therapeutic drug monitoring may be required for the carbamazepine also. Usually the carbamazepine is less used nowadays as a mood stabilizing agent. The other ones like this valproate is now more commonly used. It acts by blockade of the sodium channels, potentiation of the GABA, which is an inhibitory neurotransmitter, and blocks T-type calcium channels. In short, details you have read in the epilepsy chapter about this. Okay, so valproate is mainly very common anticonvulsant drug, which is also one of the first line agent for the treatment of the bipolar disorder as well as the manic disorder. So it is also effective who are failed to lithium also. Preferred over lithium for initial therapy, but lithium is still preferred for the maintenance treatment. So at the first, when the patient is captured, when the patient is complaining with some bipolar disorder or acute episodes of the mania, we should start with the valproate. It will be continued for some months or years. Then for the long period of time, if there is no problems as such, we can continue with the lithium. Combinations of the valproic acid with other psychotropic medications likely to be used for the management of the either phase of bipolar illness, generally well tolerated. So we can combine valproate plus lithium, we can combine valproate with some antidepressant or antipsychotic agents. Okay. Lamotrigine is another anticonvulsant that is also used for the management of this disorder, bipolar disorder, also epilepsy. It is a mood stabilizing agent. Lamotrigine is most effective in the treatment and prophylaxis of the bipolar depression. Usually it is used for the maintenance treatment, more or less similar to the valproate. Mechanism of action, again it mainly acts on the sodium channels, you know from the epilepsy chapter. So lamotrigine inhibits the voltage sensitive sodium channels. They are also blocking the aspartate and glutamate channels also. So pharmacokinetics more or less similar. Side effects, lamotrigine is very commonly associated with Stevens-Johnson syndrome. So that's why there will be a black box warning that if the patient is taking lamotrigine, there may be some Stevens-Johnson syndrome or toxic epidermal necrolysis. These are very severe skin problems that may happen when we are using the lamotrigine. So it usually develops in the first 2 to 8 weeks of the therapy, and if medication is suddenly stopped, then resumed at the normal dosage. Patients should seek medical attention when these problems arises. Apart from this, lamotrigine also binds to melanin containing tissues, and it is also deposited in the cornea also. So there may be some corneal discoloration, there somewhat skin discoloration also happens with lamotrigine. After the anticonvulsants, atypical antipsychotics, already we have discussed about the Risperidone, Olanzapine, Clozapine, etc. These are also used for the management of the bipolar disorder, usually in the combination. So this plus valproate or this plus lamotrigine can be used. Mechanism of action already we have discussed. Lastly, in case of the acute mania, we have to use the benzodiazepines. Benzodiazepines already we have read. So basically they potentiate GABAergic neurotransmission in the CNS. Diazepam in state of extreme mood elevation or extreme aggravation, agitated state, we have to use the diazepine. That ultimately gives rapid sedation. Useful until the effects of the lithium takes place, because lithium usually takes minimum weeks or months for its action. So we have to start with the lithium for the first, but usually we have to use some other anticonvulsant agent. Usually if there is severe acute episode, we have to use the benzodiazepines like this. So this is all about the drugs that are used for the treatment of the mania and bipolar disorder, and the previous ones about the antipsychotic drugs. So we have read about the depression, psychosis, as well as the mania and bipolar disorder. These are very important. Just read about this, and if any question arises, just let me know. Okay, thank you.